Um, Firstly, I would like to thank the organizing committee for inviting me to here. It's a great pleasure for me to be with you and also to be at the same panel with Professor Kaskarbi and Julia and other distinguished speakers. So today I will have a brief talk about pharmacogenomics of treatment response in depression. Firstly, I will give a brief information about the earlier studies about pharmacogenetics of antidepressive treatment, mainly the pharmacokinetic and pharmacodynamic genetic variations. And in the last few years, especially 4 or 5 years, there are few genome-wide association studies related with treatment response in depression. So these will be my main discussion topic here today. During my talk, I will mention some specific difficulties, problems related with genome-wide association studies. So probably I will also mention briefly about these difficulties. And the results of these genome-wide association studies demonstrated that rather than metabolism or transport proteins, there are novel new gene candidates or biomarkers that may be related with depression and treatment response in depression. So probably these points may be future study points. So briefly, genetic variation may be caused by variations in genes related with pharmacokinetic properties or pharmacodynamics. And to date about depression, there are some studies accumulating data about the metabolism, transport proteins, and plasma proteins related with antidepressive treatment. And also, following these studies, there are also some studies about pharmacodynamic issues like receptor polymorphisms, ion channels, some enzymes and proteins related with drug response to antidepressive treatment. First, it will be a brief information about the earlier studies. So in metabolism of most commonly prescribed drugs, cytochrome P450s in liver is very important. And among these cytochrome P450s, in general, 3, 4, 5 is most common, but considering the antidepressive treatment, the drugs used in depression, 2D6 to C19 are more common and more important cytochrome P450s, and studies are based on especially 2D6 related with this group of drugs. If you look at the polymorphisms of these genes, so you can see all these polymorphisms in the official website of cytochrome P450 allele nomenclature committee website. There are more than 100 synapse single nucleotide polymorphisms today reported to this website related with 2D6. There are many mutations. Some of them are more common, and it shows an interethnic difference. So you see it is present, it is not present in, for example, if you talk about the gene duplication of 2D6, it is not present in Oriental populations, but it is quite common in some isolated populations like Ethiopians here, and it varies even among the Caucasians. This is a very classical example related with the pharmacogenetics of cytochrome P452D6 and antidepressive drugs. So this is the plasma nortriptyline concentration against time. So normally we have two functional allele genes, and a person carrying two functional genes has an average plasma concentration time curve as shown here, but in some subjects there is no functional gene or only one functional gene, so you see the increased concentration of the drug in these subjects, and also in this unique case you see the very low concentration of the drug after the administration. So this is some, and there are many data actually in the literature. In this, all these accumulating data suggested that there should be a dose recommendation for some of the antidepressive drugs. Seringer and also the other author is Julia, she's here at the moment. They have series of review articles related with the pharmacogenetics of drug metabolizing enzymes, and they clearly showed that for some of the antidepressants, considering to the 6 phenotype, there is no need for dose adjustment. For example, sertraline, citalopram, nefazodone or bupropion. But for some drugs like imipramine, doxepin, maprotilin, so the dose should be adjusted in poor metabolizers or ultra-rapid metabolizers. And following the metabolism studies, there were many other studies, especially related with the pharmacodynamic aspects, like serotonin transporter gene polymorphisms, ABCB1 gene polymorphisms, serotonin receptor genes, glutamatergic receptor, and also some genes related with inflammation, inflammatory issues. So, but these were pharmacogenetic approaches and only involved few genes and also few mutations, single nucleotide polymorphisms related to treatment response in depression. It was in 2003 the microarray genotyping approach also was introduced to pharmacogenetics, and this was the first microarray called AmpliChip CYP450. So this allowed the high throughput genotyping of several single nucleotide polymorphisms related with cytochrome P450s. So this was the beginning. It was 10 years ago, but then later many other array technologies were introduced into the market and to use in research and also in routine use. And then genome-wide association studies have been performed during especially during the last 4 or 5 years. There are few studies, genome-wide association studies, and some of them from Germany, Mars project, German inpatient replication sample, and one was from United States, STAR-D, and also GeneDep. So these were studies, some of them were directly focused on the treatment response in depression, and one focused on some side effects, and one was related with suicidal thoughts and its relation to pharmacogenomics. In most of the studies, researchers genome-wide genotyped these samples. This is the first one published in 2009. in this study, the researchers genotyped the samples from Munich Antidepressant Response Signature project. So in this project, every subject was genotyped for more than 400,000 single nucleotide polymorphisms. And among these SNPs, they identified a few hundred SNPs which are highly associated with treatment response, and then they regenotyped or genotyped some other samples like STAR-D or German replication sample, and they identified few new gene candidates. Here in the axis you see the negative logarithmic p-value, so there are quite statistically significant SNPs related with treatment response. And in the further genotyping, genome-wide phenotyping, the researchers showed especially fibronectin-1, ADAMS-like 1, and endothelin-1 genes, and the related clusters are statistically significantly associated with treatment response in STAR-D sample. Some of these genes are related with the metabolism. Some of them are transcription factors, and some of them are important for neuronal development. For example, fibronectin 1 and some others in this cluster involved in the metabolic pathways, cell adhesion, and nervous system development and differentiation. The other cluster, which was related with treatment response in depression, was ADAMS-like 1, and other genes of this cluster are related, interestingly, with risk to certain cardiovascular disorders and also with some metabolic pathways. Endothelin and other genes were the other cluster. In this cluster, endothelin-1 is involved in vasoconstriction, and few others are related with neuronal modulation and a carrier gene. Some other researchers later performed another genome-wide study related with treatment response in depression, published in 2010. In this case, they genotyped more than, again, 400,000 SNPs by using some high-throughput methods. In this, again, they used the same sample, actually. In this sample, the patients used citalopram in different doses. In this sample, there were 883 responders and 608 non-responders. Again, they searched for high significance, and interestingly, in this research, the genes which were highly correlated with treatment response was a little bit different compared to the previous one. Of course, there were some differences, methodology differences, and also there were some differences in criteria to include the responders and non-responders. So these genes were highly correlated with, and you see the list of these genes, but the first three ones, I will just skip. This shows the response phenotype, and this shows the remission phenotype. So these, especially three SNPs, were related with the modification of proteins to signal them for degradation. One is a DNA binding protein, which is related with developing notochord of an embryo, and the other one was bone morphogenic protein. And this is the other one, which was published last year. Again, this is a genome-wide association study performed in a GeneDep project. And this time, the researchers performed this study to understand if there is an association between suicidal ideation during the antidepressive treatment and the tested single nucleotide polymorphisms. This project, the subjects either use escitalopram or nortriptyline, and they were treated over 12 weeks. And the sample that was genotyped was genome-based therapeutic drugs for depression, GeneDep, and they used again a high throughput array technology to genotype the samples. In this study, they also could show some association between certain types of SNPs and suicidal ideation, and it is guanine deaminase, potassium channel interacting protein 4, apolipoprotein O, and neurotrophic tyrosine kinase receptor type 2 gene. But especially these three genome-wide studies, they were performed in the same sample, but unfortunately the researchers could not replicate or confirm their previous findings. So later, in the beginning of this year, the researchers of these three groups, the GeneDep, Mars, and STAR-D investigators, they came together and analyzed, first pooled the samples and analyzed and performed a meta-analysis among these three genome-wide pharmacogenetic studies. And this time, results were different. They identified, after pulling the data, they identified some other new novel gene candidates as biomarker. You see some of them here. This is for the remission, and the previous one is improvement after 12 weeks. There was one point in these genome-wide studies. Okay, they showed statistically significant difference for some single nucleotide polymorphisms, but unfortunately in none of them the significance couldn't meet the criteria for genome-wide significance. So there are a few reasons for this. At the end of my talk, I will just discuss in one or two slides. But this really shows that there will be a need for further studies in larger populations. Another point is the merging of pharmacometabolomic data into pharmacogenomic. This is a good example for this type of using data. It's published in 2011. So in one study, the researchers performed a pharmacometabolomic study in which they tried to associate some metabolomic parameters or biomarkers related to and try to associate with treatment response, especially SSRIs in depression. And they showed that glycine metabolomics signal was associated with selective serotonin reuptake inhibitor response. This was a pharmacometabolomic study, but then by taking the data from this finding, they also searched the pharmacogenomic basis of this metabolomic data finding. And in this study, they showed some of the genes related with glycine metabolic pathway or pathways, and they showed that these some of these SNPs are related with SSRI treatment response. And you see some of these highly correlated or significant SNPs. This study showed another point, another important point. The inclusion criteria, especially if we are defining a clinical response. So what should be the criteria to select responsive or non-responders? In this study, again, the researchers used the same sample, STAR-D sample, and genotyped, also genotyped gene depth, but this time they searched for sustained pattern of antidepressant response, because when they looked deep into these patients, they showed that some of the patients responded well up until 6 weeks, for example, here. But then, if you look at the responders or sustained responders at 12 weeks, you see some of the responders at week 6 were not a responder anymore at week 12. So when they classified the patients as suspended responders and unsuspended responders and performed this genome-wide association study, they showed some other genes or SNPs are related with treatment response. So you see acyl-CoA synthetase, which is responsible for energy generation, which is a mitochondrial enzyme, or another enzyme, chondroitin sulfate and acetyl-galactosamine transferase. So these were highly associated with treatment response in suspended responders. And these enzymes seem to have a role in neuroplasticity or brain development or axonal guidance. And in one genome-wide association study, for example, this gene has been related with autism. And you see different SNPs which are related with treatment response in or around acyl-CoA synthetase. There were some other novel genes which are related with treatment response in this study as well. So as a conclusion, so these genome-wide association studies, they brought some new aspects, novel candidate genes biomarkers for treatment response, and some of them maybe we haven't heard before. And as we see here in the earlier studies, there were very much impact of, for example, 2D6 still there is, but unfortunately it couldn't be shown here in these studies, genome-wide studies. So it's not because 2D6 is not important in the metabolism or in response to depression treatment, but probably it's because still the methodology for genome-wide association studies should be improved. For example, even using the same samples, same patients' DNAs with different studies, unfortunately the findings could not be replicated. So in one study there was one gene which was significantly higher and associated with treatment response, but in another one there was another gene which was thought to be associated with treatment response. So but interestingly, there is one point which I should emphasize here. all these novel genes, SNPs, they were statistically significantly associated with treatment response, but none of them met the criteria for genome-wide significance. So I think the main reason to do for this is the number of samples genotyped in these studies. We have 100,000 of SNPs. We analyze these SNPs, but only in few hundred patients. So it's not easy to conclude sharply, okay, these SNPs are really significant in treatment response just by looking at the results from 300 or 400 subjects. So more subjects are needed in these studies, and the researchers should also seek for not only for statistical significance, but also should consider a genome-wide threshold for significance. And in some of these studies, there was no placebo control, and if we look at the effect of 400,000 SNPs, so one should really think about some other factors which may be related with the nature of disease. So placebo-controlled clinical trials are warranted in this area. I would like to thank for your attention. This is the end of my presentation. Thank you.